Folks, if you would, we'll begin the meeting, and please come in and feel free to find a seat there, and we'll close that back door. First of all, welcome. We're glad that you could come and have an opportunity to have some public comment on some issues that we'll be dealing with. And let me give you a little ground rules before we get started. We've got a number of people who have signed up that wish to be heard, and we certainly want to do that. And I'm going to ask that you take no more than 5 minutes. And Jesse's going to be the timekeeper over here. And when he gets to 1 minute left, he's going to give you the sign of 1 minute. And we'd really appreciate it if y'all would try to stick to that, because we got a lot of people who wanted to come and make comment, and we certainly want to have an opportunity to do that and not wear everybody out. So our feelings will not be hurt if you speak less than 5 minutes. Brevity is appreciated. And if you have some comments that you would like to leave with the committee, we'll be happy to take those. So, having said that, we're going to go ahead and get started. And Dave Zillis is going to come up first. Sorry, John. Yeah. You're on deck, though. Come on, Dave, and then you have some folks who want to come up with you, and go ahead and turn that on right there.
Mr. Chairman, committee members, my name is Dawn Alford. Not only do I speak to you today as the Acting Public Policy Director with the Georgia Council on Developmental Disabilities and co-coordinator of Unlock the Waiting Lists, but as a person who uses the Independent Care Waiver Program to maintain my independence and work full-time. Today, I'm here, along with several other folks, who have come to testify and ask that you please support the Unlock request to gradually raise the rate of the Independent Care Waiver Program personal support rate to $20 per hour so that Georgians like me can find and keep adequate caregivers. We recommend phasing in this amount, starting with a $3 per hour increase in the FY 2016 state budget with an impact of $7,975,490. The issue is this. As you can see from the graph that you should have in your hands on our handout, the Independent Care Waiver Program is the lowest paid waiver in Georgia by almost half compared to the other Medicaid waivers as well as private pay. The Medicaid reimbursement rate for my Level 1 care is between $10 to $11 per hour, which means my caregivers, if they're lucky, receive $8 to $9 per hour. This pay rate is so incredibly low that it seriously impedes my ability to find and keep quality caregivers, especially in the rural community where I live. To put this into perspective, the going rate for a babysitter in Atlanta is $15 per hour. My mother, who is aging herself in her 60s and is really at a point that, to be quite honest, providing my care is really beyond her ability because of her own declining health. And she has missed countless days of work because of my inability to find and keep quality caregivers. I could also share horror stories of what I have endured from some of my caregivers because of the inability to find good quality at such a low rate. If I may be so blunt, you really get what you pay for. This is the very issue that keeps me awake at night, because I stay in a state of worry knowing that I'm one caregiver away from a major crisis. My family cannot afford for me to lose my job, nor my mother, simply because I can't find caregivers. And the fact that remains that if all caregivers who are providing the same care very similar, if not identical, to the care that's received by people on the other waivers in Georgia. These individuals deserve to be paid a living wage for the same care that they're providing. I implore you to please address this disparity by providing funding that will bring the independent care waiver program up to the rates of the other Medicaid waivers in Georgia. Again, we recommend phasing in this amount, starting with a $3 per hour increase in fiscal year 2016, which again would have a budget impact on the state budget of $7,975,490. I appreciate this committee for taking the time to hear my concerns, and I'm happy to answer any of your questions at this time.
Thank you, Dawn. Do we have any questions or comments from the committee? Anybody? Thank you.
Thank you.
Dave, you had one more person with you that wanted to be heard.
Coming up.
Okay.
And I might add, we had 32 people that were interested in giving their testimony, but we didn't want to have them all come, so they wrote you one.
Okay, thank you.
Good afternoon, Chairman Parrish and committee. My name is Margo Waters, and I am a resident of Atlanta, Georgia. I am currently receive support through the ICWP waiver program, and I need the support that I receive through that program. It helps me be able to work and be independent, as well as I'm now a taxpayer. Receiving services through the ICWP program gives me personal care assistance, so I am able to be independent. Without the ICWP waiver program support, I cannot do these things. I receive 6 hours a day and personal care attendants who get paid less than $10 an hour. My issue is finding personal care attendance for 2 hours in the morning from 7 a.m. to from 5 a.m. to 7 a.m. and returning again to help me with activities of daily living for 4 hours after I get off from work in the evenings. In my role as an independent living coordinator / housing advocate at Disability Link, I assist others with disabilities to apply for the independent care waiver program. Raising the rate would help individuals find and keep personal care assistance. I respectfully request your support. This waiver is very important to me and many others in the community. Raising the rate of support to $20 an hour will help Georgians find and keep adequate personal care assistance. We recommend phasing in this amount, starting with a $3 per hour increase in the fiscal year 2016 for the amount of $7,975,490. Thank you.
Thank you. Any questions from the committee, comments? Thank you very much. Did we have one out here? Let's see. Representative Hughley, I think you had.
Thank you, Mr. Chairman. She might not be the one to answer this question, but I was just curious, if we go to the $20 after the home health agency takes their administrative fee, what would be the real number that the assistant would actually get?
Dave, can you answer that, or maybe Dawn?
Well, when we actually went out and studied and called the home health agencies, those are actually the rates that they would get. They will get $18 to $20 an hour. The individual would.
Okay.
So that's a rate that is paid. So that's what they would be. If you went out there and hire one like I do for my son, it'd be $18 to $20 an hour.
Okay. So when we go to the $20, that's exactly how much the caregiver would get?
Caregiver would still, out of that amount, it would still, much like the other two waivers, it would still require taxes and workman's comp out. So you'd still be up in the $15 to $18 range.
Okay.
And their testimonies are in that the book, Shelley?
Thank you very much, and to the committee. I appreciate the opportunity to speak with you today. My name is Shelley Simmons, and believe it or not, in a couple of months, I will be 50 years old. I currently reside in the basement of my aging parents' home in Powder Springs, Georgia. For nearly 20 years, I have relied on personal care workers to assist me in my daily activities. With each passing year, I become more and more dependent on my personal assistance. I have a form of muscular dystrophy that continuously deteriorates the muscle. Consequently, this has interfered with my ability to bathe and dress myself, transfer in and out of my bed or wheelchair, and so forth. But once I've been assisted with these tasks, I'm fairly independent. I drive, I'm active in my church, and I'm currently working 5 days a week at a job that requires me to have a very flexible schedule and to travel in and out of state. But none of these things would be possible without the worker who gets me up and ready in the morning, is there some evenings to greet and assist me when I get home from work, and to travel with me. Because I have to divide my allotted hours throughout the day, usually 4 hours in the morning, 4 hours in the evening. It's very hard to find someone willing to travel to Powder Springs twice a day on the amount of money my budget will pay for their service. I therefore have to depend on my parents for my assistance. My father and mother will be 78 and 73 respectively this year and have health issues of their own. My father, who has prostate cancer, has regular attacks of Bell's palsy, and is in early stages of dementia, is not always an option for help. My mother is a breast cancer survivor, but the chemo, radiation, and surgery has left her weak and is also not a viable option for assistance. That's when, I find myself sleeping in my chair until 5 or 6 o'clock in the morning. That's when my father is rested and in his right mind to help get me in the bed. Or when my aide comes in, do I lie down for a couple of hours until I have to get up in the morning and get myself ready for work. Additionally, I have 3 aides on staff, all of whom receive just a little over $11. But there are times when I do not have coverage, whether it is a car that is in need of repair or a sick child. I sometimes have to ask an aide to work additional days. Yet some aides go above and beyond what is expected out of the kindness of their hearts. And it is only because of their passion that they have for their clients and their jobs that they're able to do this. Unfortunately, my story is not unique. Many people with disabilities on the waivers have similar problems. I've been fortunate to have some wonderful aides work for me, but never for too long. Many have told me that I live too far for them to make money, and they either move to other programs that pay more or seek employment within the city in order to have 2 or more clients in order to make the ends meet. This is why there needs to be an increase in the rates for ICWP workers. The disparity in the rates among the waivers is unconscionable. And in order to have and keep good, honest, and qualified people in our homes, providing a service that is imperative, there has to be competitive compensation. So I want to thank you in advance for your careful deliberation on a matter of great importance to people with disabilities. I humbly yet insistently ask that you please increase the rate for ICWP workers. Without these dedicated workers, my independence will be greatly and negatively affected. Thank you for your time.
Thank you. Any comments or questions from the committee? Thank you very much. Appreciate you being here.
We have one other, but she can come to the podium and she can go back to the original schedule if you want.
Well, let's go ahead if you're here, and we'll.
Chairman and members, my name is Linnea Mishra. I'm currently living in North Georgia and Ball Ground, Georgia with my son, George. I have lived in Georgia for many years, including college here, but I grew up in South America. One of my first jobs was as parish liaison coordinator for in-home nursing services for Catholic Social Services. This helped prepare me for my son's unexpected disability. Our son George is currently on the ICWP program and has been fortunate enough to receive these services for the past 7 years at a rate of $8 an hour. He receives 10 hours a day. Experienced caregivers require $15 an hour. We are requesting your support to unlock the waiver. It is critical to gradually raise the personal support rate to $20 an hour so we can find adequate, dependable caregivers. We recommend phasing this amount starting with $3 an hour in the fiscal year of 2016. As stated before, experienced caregivers are now requiring a minimum of 15 or more. The current rate makes it next to impossible to find qualified caregivers, especially for patients requiring a higher level of care, as my son does with a dual diagnosis, traumatic brain injury and mental illness. These unqualified caregivers who are paid low wages, and the low wages are a catch-all for employees that tend to have little or no experience, to be irresponsible, negligent, do no-shows, oftentimes victimize patients and families, steal, may have falsified background checks, sometimes bring transmitted diseases, and have no training in helping patients with their daily skills, medication management, and other necessary skills depending on the individual patients and diagnosis, making it very difficult for the primary family member caregiver. This does result in job losses, wages being cut by that caregiver to less than half because of having to fill in and do their job too. My job has been to go to the different courtrooms as a Supreme Court certified interpreter in Spanish. An example of different kinds of incidents of theft happens when we are really in an unexpected situation, as last summer I had eye surgery for a cancerous lesion on my eye. Fortunately, we caught the caregiver right away. During those vulnerable days, the caregiver I had took my credit card and started withdrawing like crazy. I had a patch on one eye. In addition, unexpected circumstances do occur. An example of this is almost 2 years ago. I was in a very serious car accident, suffering lasting injuries, having been hit head-on. I am a senior citizen, and since then I have not been able to go back to work due to the level of pain and injuries. My job required me to be very focused and multitask at home and travel. This income was seriously needed and is to make ends meet. It had already been cut in less than half because of irresponsible caregivers. My daughter and I are sometimes haunted by the thoughts of what would happen to her brother if anything happened to me or I were hospitalized. He would wind up being hospitalized over and over or wind up in jail due to unqualified caregivers and the lack of resources. To show you how bad it is, my family doctor said his brother had to turn his son into the streets for lack of support of his illness. Also, a nurse practitioner at my son's neuropsychiatrist's office made a very clear suggestion to me that what Georgians do when they get to the point of burnout and lack of services is that they feel they have no option but to drop off their disabled in the streets of Georgia and move to an unknown area. This, as a vocational rehab representative comment, was a very sad state that we were in Georgia as Georgians. Yet there are many families who care about their loved ones. Their voices aren't being heard today. They have carried their share of the load for many years. We request most respectfully that you seriously listen to our request to increase this amount. It will impact individuals greatly and their families who are seriously affected by this. It will also, and you need to understand that these tragic circumstances have a riveting effect on these family members and individual patients without support. They sometimes just don't have a life, but continue doing what is right. Your decisions of supporting this change will improve not only the quality of care for patients and families, without improving in these systems, without making an improvement in these services, patients are at risk to more hospitalizations, jail, emergency room visits. These emergency room visits are extremely costly, but they seem to be a catch-all for no other services. Sometimes they're necessary, of course, but when they're not necessary, they increase the state budget of health care. We ask you to please support with this increase.
Thank you very much. Appreciate you coming and being with us today. Next on my list, John Howell.
Mr. Chairman, distinguished members of the committee, I'm John Howell, and you'll notice from the cover sheet there the dual branding with the Georgia Healthcare Association and the Georgia Center for Assisted Living, representing 340 skilled nursing facilities throughout the state, 47 assisted living members, and 100% of the source case management agencies across the state, with services in all 159 counties. If I may, I'll direct your attention to the first chart in the packet, which shows the nursing home Medicaid reimbursement rates across the Southeast. And you can see there the red bar shows the net rates for reimbursement, and Georgia is the lowest in the southeastern United States by more than $50 to our neighbor to the south, Florida, with the highest in the Southeast. The other thing that I draw your attention to is the blue part of that graph, and that is the provider fee, the self-imposed fee that providers pay into to fund the program. And you'll also notice that that is one of the higher ones, and we're maxed out. The federal government only allows us to levy down dollars up to 6% of revenue. And so in Georgia, we're at that 6% level, and you can see other states still have room to add to help support their program. But unfortunately, here in Georgia, providers have done all they can to help the state fund this very vulnerable population. Our next slide, the pie chart there, shows you that 72% of those we care for, almost 3 in 4, are on the Medicaid program. And that, I really think that's relevant where you're thinking about programs that are underfunded, which ours is over $10 per patient day. But we really don't have any space there to make it up. You have Medicare representing 12%, and then you have other, and that part of the chart shows 16%. If you add the VA in there, really only 1 out of every $10 is coming from private pay insurance. And so if we don't have this safety net of Medicaid properly funded, then you can see providers really have a business plan that's not sustainable. The last page is a summation of the budget that, request that was in the governor's budget recommendations. The first line there, if you'll follow the column that says state share, it says the governor's budget, and that acronym CHOW stands for the change of ownership language. The governor recommended appropriating $8.7 million in state funds. We do have a revision number for your consideration. As you can imagine, when there's a change of ownership, and that language spoke to a change of ownership after July 1 of 2012, when you have a change of ownership, you might have systems that are very expensive that have to be put into place. You may have electronic health records that need to be purchased. You may have additional labor costs. And so certainly some of those change of ownerships will have additional costs associated with it. The reason we think this number is different than what was originally recommended is to account for those change of ownership where efficiencies were put into place. You had a new operator come in, perhaps a multi-regional facility where they have additional bargaining powers with various vendors, and so we believe some of those change of ownership will result in lower cost. And so we've got a state number there at $5 million, freeing up $3.7 million. On my strategic plan at the Healthcare Association, our number one priority is to update our cost report. That's what's in the state plan. And currently we're on the 2012 cost report. Our request is to go to the 2014 cost report. The number you see there shows that that's a state funding of a need of $11.8 million. Also, with the property component of our rate being another $800,000 for a total need of $12.6 million in state funds. With the funds made available by the revised change of ownership funding, that would be a state request of $8.9 million to go to the 2014 cost report and update our RS means property component of our rate. So, Mr. Chairman, in an effort to shamelessly win favor with the committee, I'll stop there and respond to any questions you may have.
Good. Thank you. Any questions from the committee? You did a good job, John. No questions. Thank you. Next, Dr. Wayne Hoffman.
Good afternoon, and thank you, Chairman Parrish and committee members, for allowing me to speak on the issue of appropriate payment for physicians, specifically family physicians. My name is Dr. Wayne Hoffman. I'm a family doc and president of the Georgia Academy of Family Physicians. Over my career, I've practiced in a variety of practice settings, including a rural mountain community, free clinics, and corporate medicine here in Atlanta. The Georgia Academy has over 2,700 members spread out geographically throughout our state, very similar to Georgia's population. Family physicians are more geographically diverse than any other physician or clinician group. We are the only medical society devoted solely to primary care. Nearly 1 in 4 of all office visits are made to a general or family physician. Today, family physicians provide the majority of care for America's underserved and rural populations. In this increasingly fragmented world of healthcare, where many medical specialties limit their practice to a particular organ, disease, age, or sex, family physicians are dedicated to treating the whole person and the whole family across the entire spectrum of ages. Family medicine's cornerstone is an ongoing, personal, patient-physician relationship focused on integrated care and coordinated care. This background is important as I am here to ask you and the other members of the General Assembly to support increasing payment for Medicaid physicians after a lack of any increase in the past 14 years. Over 70% of our members accept Medicaid patients, which for family physicians includes children, adults that are aged, blind, or disabled, and pregnant women. Our ongoing request is to increase Medicaid payments to be on a par with Medicare for all services and all physicians. However, we know that an increase like this is unattainable in just 1 year. Therefore, we ask that this year, the General Assembly begin the increase with a smaller set of services for primary care physicians and obstetrician gynecologists. A study from the New England Journal of Medicine was published just 2 weeks ago that looked at the 2-year Medicaid-Medicare parity increase that the federal government provided for all Medicaid primary care physicians. While the study was small, it did include Georgia. It showed that access to office-based care was significantly enhanced, and it was correlated to the increased payment. I can think of no other industry that could survive without an increase for even a few years, much less 14. Even without Medicaid expansion in our state, Medicaid enrollment is increasing. Increasing payment and thus access to primary care physicians will benefit our vulnerable and underserved Georgians. Our staff has just provided you with copies of this New England Journal of Medicine study for your review. With almost 20% of Georgians receiving care through Medicaid or Peach Care, we need to provide access to primary care outside of the emergency room. Everyone should have access to a medical home. Family physicians want to care for our Medicaid patients, but we are financially unable to add increased access to our practices without any Medicaid increases in 14 years. We look forward to continuing to work with you, Chairman Parrish, and your subcommittee on the budget for 2016. I appreciate you giving me time on the agenda, and I'll be happy to answer any questions you may have. Thank you.
Thank you, Dr. Hoffman. Any questions or comments? Yeah, here we go. Okay.
Thank you, Mr. Chairman. Dr. Hoffman, I'm interested in your report that with the enhanced rate that came with the Affordable Care Act, that the number of visits to patients, Medicaid patients, actually increased.
Yes, that's correct.
By a significant amount.
Yes, significantly.
And as you go back to the former rate, what is the year at which your current rate is pegged? Is it 2012, 2014?
We would be asking for a 2014 parity for Medicare 2014.
And do we have a number that would cost?
The actual number for those codes that the primary care codes, I think it's approximately 50 million, 60 million.
50 or 60 million?
About 60 million, I think, is the closer number.
And you have no recommendations about where that money should come from?
Personally, I would say that certainly there's other options on the table. The tobacco tax would be one of them.
Any others?
I would say there's probably some money that can be found that has not been used in the past as well. I think the tobacco tax increase would be wonderful, and also we are talking about the transportation money that needs to be raised. There's a lot of money that could be on the table there.
Anyone else? Dr. Hoffman, thank you very much.
Thank you.
Next, Rick Ward.
Thank you for the opportunity to present before the committee. We're going to follow up on the comments of Dr. Hoffman to give you some pediatric perspective on the same issues.
If you would, please just identify yourself
Yes,
and
sir.
which group you're with, okay?
So I'm Bob Boyskin. I'm a general pediatrician in private practice here in Atlanta, and I'm the immediate past president of the Georgia chapter of the American Academy of Pediatrics, which represents over 1,700 pediatricians from around the state. So I'm going to share with you some numbers that you may be familiar with to give you the pediatric perspective on Medicaid. Approximately 2/3 of the people who benefit from Medicaid are children, but they use only about 1/3 of the costs of Medicaid. Across the state, about 60% of the births are under Medicaid, and currently roughly 43% of children in the state are covered by Medicaid. There are many pediatricians in the state whose practice is 60 to 70% or more Medicaid. So Medicaid is the lifeblood of pediatrics. Access is an issue under Medicaid. There are currently 23 counties across the state that have no pediatricians and another 61 counties that are underserved by pediatricians. In a recent poll, 40% of the pediatricians in the state said that they would close their practice to Medicaid if reimbursement was not improved. There are practices that are closing because they can't make a go of it financially under the current Medicaid system. And one of the problems that we have is getting new doctors to come and practice pediatrics in Georgia. We produce them out of medical school. We're adding residency slots to continue their education, but then when they see the economic climate in Georgia, it's hard to get them to stay. The finances. Medicaid rates are typically about 2/3 of Medicare rates and about 1/2 the rates of commercial plans. Over the last 2 years, the Medicaid rates were increased to Medicare levels, and that attracted new pediatricians to accepting Medicaid or seeing more Medicaid. But as you heard, there hasn't been an increase in these rates in the last 14 years in the state. And one thing to add about, there's a lot talked about in the legislation in the state about education and about doing a better job educating our kids. Pediatricians know that kids can't be educated if they're not healthy, that we can't get them to school if we don't have a system that allows us to care for them. So in closing, before I introduce my colleague, we're urging the state to find the funds for Medicaid parity, to do what Alabama and South Carolina and Mississippi have already done, to use state funds for that purpose. So I'm going to turn it over to Dr. Sami.
Thank you, Mr. Chairman and members of the committee. My name is Cyrus Sam. I work with Sibley Heart Center Cardiology. I'm the Director of Outpatient Operations, which gives me oversight over 21 clinics throughout the state of Georgia with over 30,000 patients that we see annually. I'm representing pediatric subspecialists on behalf of the Georgia American Academy of Pediatrics, 45 cardiologists within my group, and 200 employees at Sibley Heart Center Cardiology. We're one of the largest groups in the country. In the last 2 years, we've been ranked number 4 in the United States by U.S. News and World Report. While that statistic doesn't make me proud, what makes me proud is that we offer world-class pediatric cardiology care to all children within the state of Georgia. We provide access to them. My practice illustrates an example of how access to care improves when Medicaid reimbursement is on par with Medicare. With the augmented Medicaid rates in 2013 and 2014, we were able to open offices in areas that were in desperate need of pediatric cardiology services. In 2014, we were able to open an office in Albany, as well as one in Valdosta, and I'm proud to say that in March we're opening up an office in Thomasville, Georgia. Recently, a pediatrician in Albany diagnosed a murmur in a 2-month-old boy, and that boy was able to be seen within 24 hours. My partner, Dr. Benjamin Toole in Albany, diagnosed that baby with severe narrowing of his aortic valve, which placed him at high risk for sudden cardiac death. The patient was operated on, and 2 months later, that boy is doing quite well. Having pediatric cardiology offices throughout the state keeps patients closer to home. A baby with a congenital heart defect born at Northeast Georgia Medical Center has a better chance of staying with his family at home because we have a cardiologist in Gainesville. Patients with congenital heart disease in Macon can be seen quickly because instead of taking a 2-hour ambulance ride or an expensive helicopter flight to Children's Healthcare of Atlanta, because we have 3 pediatric cardiologists in Macon. Patients can stay close to home. Parents can visit their kids in the hospital and take care of their kids at home and miss fewer days of work. We are serving areas in the state in which 60 to 80% of the children rely on Medicaid. Losing the augmented reimbursement rates can be financially untenable and have catastrophic consequences, with the possibility of closings of offices in Macon, Albany, Columbus, Tifton, Dalton, Gainesville, and Athens, where those areas have 60 to 80% Medicaid. Reimbursement for the care of a child should be no different than that of an adult. Closing offices with a higher dependence on Medicaid will only cause 3 things to happen. Parents will have to drive further to have their children seen by subspecialists. Parents will often elect to have their children treated in expensive emergency rooms by people who are not trained in the pediatric subspecialty care. And third, appropriate care will be delayed, outcomes will not be as good, and mortality will increase. I can give you an example of a baby that was in Dalton at Hamilton Medical Center, had an echocardiogram that was read by an adult cardiologist. That baby showed up urgently in our office in Dalton a day later, pale and limp, and was diagnosed with a critical congenital heart defect that required urgent life transport to Eggleston Children's Hospital, and the kid was operated on that same day and is now 4 years old and doing well. That's what happens when non-pediatricians take care of pediatric patients. This is about access. In summary, I urge you to take action that would create parity between Medicaid and Medicare rates in the fiscal year 2016 DCH budget. Without any rate increase in 14 years, physician practices are reaching their breaking point. Long term, having effective health care system for all Georgians depends on reasonable payment levels. Making the Medicaid payment system on par with Medicare will only have an enduring and profound effect on our state's children. Thank you very much, and I open up to any questions.
Thank you, Doctor. Any questions from the committee? Thank you. No. Next, Pat Koda.
I'm Pat Koda with the Georgia OBGYN Society, and if I might introduce the president of our society, Dr. Ann Patterson, who's been able to get away from her practice to come and speak with you today.
Thank you. I represent the obstetricians and gynecologists of Georgia as their current president, and I practice maternal fetal medicine. As a perinatologist, I've been able to see high-risk patients throughout the state, and last year I had the opportunity to demonstrate that to the House and the Senate through telemedicine, as I was with a physician that was able to show this, and this is what I do every day, is through telemedicine. So it has given me the advantage of seeing the care and or the need specifically that is in the state. To illustrate this, I think Pat has passed out a map. There is a gray map that shows you the closures of labor and delivery units up to through 2014. And what this shows us is that there are 31 OB closures, and out of approximately 180 hospitals in Georgia, we have 75 labor and delivery units to serve 159 counties. Of those 75 labor and delivery units, 15 are in the metro area. That leaves about 60 to serve the rest of Georgia. Obviously, there are glaring gaps. This is very important because if you have an obstetrician, they have to be able to deliver care at a hospital that provides that care. They have to live close by, that's a requirement. Obviously, babies deliver 24/7, so we have to have access to that, both for delivery and or obstetric emergencies. The green map, which you will see, was done in 2011. And what it shows you is that there are adequate areas in the Atlanta area and in the white counties. Other counties are either at risk or have a deficit or no OB services. The dark green show no OB services. And you will see east of Athens, going towards the coast, there are a lot of counties that are dark green. Overlaid on this map are the recent closures, some which were adequate, but if there isn't an obstetric unit there, they can't provide the care, and those counties now become dark green. Burke and Washington counties amongst those. So once again, it leaves us with a glaring deficit of delivering services to patients, and patients are often traveling a large distance. Obstetricians may see patients from 8 to 9 counties that are surrounding them. There is a recent study that was done that shows that women that commute more than 45 minutes to delivery have a 1.5 times more likely to deliver a preterm birth or preterm infant than those who deliver and drive less than 15 minutes. From 1999 to 2009, a quarter of the women in Georgia needed to drive more than 45 minutes to get services. So you can see that we do have some glaring deficits. In order to help with this, we need to have obstetric units, we need to have obstetricians, and we need to have care to be able to provide this. If you don't, we can see that NICU infant care costs about $5,000 a day. With Medicaid paying for 60% of the births in Georgia, that's costly for the state. And immediate afterbirth and long-term care in those children is also high. This is especially tragic because with adequate obstetric care, a large part of this can be prevented. I am gravely concerned that diminishing access to care in the rural communities is only going to make this worse. Obstetricians who provide care there often have 70 to 80% Medicaid. And if Medicaid fees have not been increased, as you've heard from others, over 14 years, that leaves us with inadequacy and obstetricians who can't keep their doors open or can't attract others to practice with them. We obviously understand their budget constraints, but across the board, we think this would make a huge difference for Georgia, for Georgians, for obstetric care, and for our children as well. I appreciate your time in considering this difficult problem. I'm happy to entertain any questions.
I've got one question for you. In some of these areas where we don't have the obstetric care that maybe we did have, or how is that affecting like some of our rural hospitals where they lost that care? I'm guessing that might be a negative as far as the revenue that's generated to the hospital there. So could you talk about that just a minute?
Well, sometimes obstetric units are not a money-winning proposition for hospitals. They can be a losing financial situation, and I think that's been some of the driving reasons that those units have closed. So as opposed to beefing them up or making them more viable, hospitals have opted to close them, which leaves the populace in a grave situation, often having to drive over several counties to even have obstetric care. And that includes not just obstetricians, but family practice physicians that deliver or nurse midwives that deliver. All have to have a facility.
Thank you. Any other comments or questions? Thank you.
You're welcome.
Next, Beth English.
Good afternoon, Mr. Chairman. And I'm not Beth English, as many of you know. I'm Helen Sloat. I'm here on behalf of the Easter Seals Coalition. Ms. English is suffering a little bit from laryngitis, so I'm going to be her voice today. We wanted to come and talk with you a little bit about the Champions for Children program. As you know, it started in 2006 with the General Assembly putting in some funding for that. And then again, last year in 2014, you added an additional $250,000. When the program was initially set up, it was to serve 192 children on an annual basis, where families were to receive up to $2,600 for the services that Easter Seals was going to fund. Easter Seals was providing all the administrative costs in that program. As of the end of last year, we have 321 active children in the program. There are another 65 children currently in the intake process. At the moment, we have funding from all sources at $450,000, and to serve the children, we have calculated that we need $772,000 on an annual basis. And you will recall that we had to lower the amount from the $2,600 that those families were receiving to $2,000 in order to stretch the money further. And I believe that was done 2 years ago or three years ago. So we calculate that we have a gap in the funding of this Champions for Children program at $322,000, and that would be to serve the 321 children that are active plus the 65 children that are on the intake process. You will also recall that to be eligible for Champions for Children, you have to have a medical denial from Katie Beckett. That's what this program is actually serving, is the Katie Beckett waiver children that were originally rotated off the waiver process back in 2006. I'm happy to try to answer any questions. We'd respectfully request the additional funding for the program. Many of the children that are served by the Champions for Children program have autism spectrum disorders. And other children have metabolic issues, such as they have food disorder issues and those types of things. I have a report here I can give to you. I believe that some of you may have received this report at an earlier hearing, but I'm happy to leave an additional one.
We've got a question for you. Representative Gardner.
Thank you very much, Mr. Chairman. I mean, last year we put a one-time increase in the Easter seals.
No, that was, you're thinking in 2006. It was a one-time funding for the program. Last year we came to you and said, we have stretched this funding from 5 years, what was originally to be funded, to 7 years last year. We're continuing to serve those children. We don't have the money to serve the children, and that's why we had asked for an additional amount of money last year for $200. We actually asked for $500,000, and we got $250,000 in last year's appropriation process.
And where exactly did that go in the budget?
It's in the Department of Community Health budget, and I believe it's under healthcare access and improvement, if I'm correct.
Okay. Other questions or comments?
Thank you.
Thank you, ma'am. Marcus Downs. Thank you.
Good afternoon, Mr. Chair, members of the committee. My name is Marcus Downs. I represent the Medical Association of Georgia. We represent over 7,500 physicians across the state based on demographic, based on employment status. A very large number of our members are independent physicians, and I come to you on their behalf today. You've already heard from several physicians this afternoon, so I really just want to say amen to their points, but I also want to raise some other issues. I think the first thing is we want to thank you for what you've been doing with the healthcare portion of the budget. For the past couple of years, you've made very affirmative steps in funding our residency spaces, which I think is one of the first ways that we can address the access to care issue. And additionally, while we have not seen any increase in the reimbursement that physicians have received, we also haven't seen cuts that several other places in the budget have seen. So we're very appreciative of that. We know that you all have a very tough task before you. I agree with everything that the speakers have said. This is an issue of access. One of the things that has been highlighted in one of the studies is that there's been almost 45% of physicians not accepting new Medicaid patients. Now, in 2009, we received data from the Department of Community Health that said that the number of physicians accepting Medicaid patients was down by 16%, or more accurately, 15.9%. So I'm not sure if that data actually referenced physicians who had dropped Medicaid patients or physicians who were not accepting new patients back in 2009, but that in of itself is a startling figure. I want to also point out that roughly 65+% of the births here in Georgia are Medicaid births. And so for that reason, we think it is very important that you continue the Medicaid parity piece. As far as an economic impact goes, with parity, physicians, primary care physicians, are looking at roughly 35% cut in their payment. That on top of what typically happens with the federal government and the sustainable growth rate, physicians normally look at a 20+% cut every single year. On March 1st is when the federal government has to begin looking at taking an action to make sure that those cuts don't actually make it into the budget. And, you know, as one of the speakers said earlier, it will be very challenging for anyone to balance a book or to make sure that they can keep the doors open of their business when they're facing 20+% cuts every single year. If your committee, if this House of Representatives, if our Senate are able to favorably look at this Medicaid parity piece, that would definitely be something that benefits our community as well. The last thing I want to point out is that primary care physicians account for about $7 billion, and that's billion with a B. I can provide that study for you as well. And the study also says that they account for 61,000 jobs throughout the state of Georgia. So primary care physicians are an economic driver for our state. They're necessary and obviously to provide access. And with that said, you know, we'd ask that you favorably consider continuing the Medicaid parity payment. We know it is a huge ask, and so if it requires some creativity, then we are fully in support of that. The one piece that we would definitely like to make an ask for is that OBs are included in the parity as well. Last year they were not. Some of the data that you're going to receive is probably going to be a little bit skewed because they were not included in that, and the fact that the payments actually didn't kick in until probably 4 to 7 months after the fact. But I'd gladly take any questions that any of you have.
Thank you. We have a question. Representative Gardner has a question for you.
Thank you very much, Mr. Chairman, and I'm concerned to hear about the reduction in the number of physicians in our Medicaid program. And we heard some evidence today about the enhanced reimbursement rate as a result of the the ACA. And I just wondered if you had any suggestions about how we might find the money to enhance those rates. Does your association come up with any suggestions about how we might go about that?
Not to be coy, I think one of the challenges that we have as an association in making those type recommendations, we've obviously signed on to the tobacco tax. There are other items that we believe probably could be quote unquote taxed and provide a new stream of revenue. However, we also are under the understanding that it requires some type of constitutional authority, that we cannot simply earmark monies to go toward a particular pot. And so with that, we're as hamstrung as you all on the committee are. But we would like to bring forward any other creative ideas. Maybe that means that, while we'd love to see the full $59 million, if that means that we need to consider $50 million just to make sure that the payment is made across the board, then that is definitely something that we would entertain and take to our members as well.
Well, we would love to see that enhanced too, and I just wondered if your association had taken any position about where those funds might come from.
We show deference to the wisdom of this committee and the wisdom of this body.
I didn't hear your answer. Do you mind repeating it?
Yeah. He said it was up to you to come up with where you're going to find that $59 million. Any other questions or comments from the committee? Thank you, Marcus.
Thank you, sir.
Nicole Walker.
Thank you, Mr. Chairman and members of the committee. I just wanted to verify that you have Sandy Marcus following me. When we signed up, we weren't 100% sure if she was going to be able to make it, so. Sandy Marcus. She is. Okay, perfect. I am an occupational therapist. I work in Gainesville. I have been in practice for 14 years now and have worked with children in the Medicaid system and have not seen a rate increase in 14 years either. So I understand what the physicians are talking about. Most of the patients that I work with are children with chronic disabilities like Down syndrome, autism, cerebral palsy. Other children have suffered debilitating brain injuries where they were typically developing and now are suffering with challenges. Probably 90% or more of the children that we work with are recipients of Medicaid in some way, either in the DME waiver, fee-for-service, or the CMOs. Because I'm in the Gainesville area, we also do get some referrals for adult patients that are Medicaid recipients, primarily because of all the administrative requirements that providers have to go through in order to get authorization for adult patients and pediatric patients to be treated by occupational and physical therapists. A lot of the larger practices that specialize in adults won't see Medicaid patients in our area. And so a lot of the local physicians refer them to us as well. I am in private practice. I have about 10 full-time equivalent therapists that work with me. With those 10 therapists, I have to have 4 full-time support staff that just deal with the administrative requirements that Medicaid and the CMOs have for the prior authorization process and all the documentation and the billing and all the things that go along with being able to provide those services and get the reimbursement that we have now. In addition to that, of course, we have our overhead expenses of keeping our facility open. And to be honest, it is getting very difficult to keep our facility open. As a practice owner, honestly, I've probably worked for 5 years now just for very little money just to keep my practice open. I have, we have patients that travel very long distances to come to our facility. They're even in the further northern regions of Georgia, and they don't have any facilities or providers in their area, especially those children that are in the CMOs. I just recently, actually just the day before yesterday, got a call from a nurse from Children's Healthcare of Atlanta who had a referral for a 1-month-old baby that had cardiac issues and is unable to swallow, being fed with a nasogastric tube right now. And they live about an hour from our practice. And she called and she just said she was hoping and praying that we actually had a provider in our organization who had the skills to be able to treat that child, because we were the only facility that she could call. Otherwise, they would be having to travel several, 2-3 hours to Atlanta or however long it took them to get there on a regular basis. I don't know how long we can honestly continue to maintain our facility and our practice at the current rate, and I would appreciate your consideration in a rate increase for occupational and physical therapists. I know that you already heard from a spokesman for the nursing homes to speak to the need of updating the cost reports which impact reimbursement rates. We are providers serving the other end of the spectrum, which is the children, and they have similar needs. One of my peers will be up later to give you more details as far as the budgetary impacts and things like that.
Okay, Representative Gardner has a question for you.
Just a quick question. The
Yes, ma'am.
rates that you currently receive, are they the same level of the Medicare rates, 75%, or of the Medicare rates, do you know?
Percentage of the Medicare rate?
As the physicians do?
I'm not 100% sure. I think
Would
that
you see if you could get that information for me?
one of my peers is going to be speaking with you, and I know she has more details on specifics as far as.
I would be interested to see if it is a comparable rate for physicians and OTs and other providers in the Medicaid system.
Yeah, I know
Thank
that
you.
we're being currently paid at the 2000, what is it called? What's that? 84% of the 2000 rate, yeah.
Is that the same as physicians currently receive? Yes. Thank you.
Okay. Thank you.
Thank you.
Hello. Thank you, Mr. Chairman and committee. My name is Sandy Marcus, and I am the grandmother of twins that are severely impacted by autism. And we live in Bartow County. Currently, they are on Medicaid, and we travel 80 miles round trip for them to have occupational therapy, which is very critical to their development and to their lifelong prospects of leading independent life. We do not have an occupational therapist in Bartow County. At one point in time, we had a great support group there in our county, and we actually paid the rent on a small house, and that worked for about 2 years. And even with us doing that, the occupational therapist could not afford to continue to service clients in our area. Majority of the clients, I was told, in Bartow County was about 90% Medicaid recipients. So what happens to families like mine is that our choices are very limited. for who our children get treatment from. And at times that access is even denied. Many of the families are in vehicles that have several 100,000 miles on them, and they simply cannot drive that distance to get service for their children. I agree with everything that's been said in here today. I thought it was only going to be about the OT portion of things. I did not realize the scope of this meeting today. Many things that have been said impacts my family a great deal. And I thank you for your consideration today and for hearing all the comments that these great folks have brought before you today. Thank you.
Thank you. Any questions from the committee? Comments? Thank you, ma'am.
Thank you.
Kim Littleton.
Mr. Chairman, members of the committee, thank you very much for allowing me the opportunity to come speak to you today. My name is Kim Littleton, and I serve as Executive Director of the Georgia Association of Emergency Medical Services. The major portion of my comments today will be directed as follow-up to some of the comments that you heard last week during Dr. Dennis Ashley's presentation from the Georgia Trauma Commission. The Georgia Association of Emergency Medical Services represents the EMTs, paramedics, EMS directors, and EMS educators across the state. And we also serve as a contracted agent to the Georgia Trauma Commission, which receives approximately, for the EMS community, approximately 20% of the super speeder funds that go in to make up the Georgia Trauma Commission. Just as a follow-up, one of the slides that Dr. Ashley presented last week gave some of the statistics on how the money is broken down, and the 20% that goes to EMS. It listed several of the projects that are part of that, but I wanted to provide you a little bit additional information on that. One of the projects that we have is that we provide first responder grants, and over the course of our serving as a contracted agent to the Trauma Commission, we have trained over 2,000 first responders across the state. And in many cases, from what you've heard today, and as you know, with the closure of rural hospitals, those first responders become very important in the delivery of health care. In many of these areas where we've had hospital closures, the emergency medical service, in many of those cases, is the only medical entity available to patients in that area. And in a lot of the cases also, if an EMS service is providing a service for these areas, they are literally transporting every patient in those communities out of county to get care, which also leaves a strain on the emergency medical service in the number of medical employees that you have in the county to cover those patients that they're there to cover. Also, we have provided training for over 750 EMS providers in pre-hospital trauma training through grants that we provide through GAEMS. In many of these cases also, that trauma training is necessary for our EMS providers across the state, because unlike in more of the metropolitan areas, literally these paramedics and EMTs in some cases are providing treatment in the back of an ambulance for these patients for somewhere over 45 minutes to an hour and a half while they're transporting these patients to the necessary facilities. One of the things that we feel like that we have been able to accomplish is that we have strong partnerships and collaborations with several groups. One thing that we have done is we've provided over 1,000 AVLS units, which are automated vehicle locator system units. We are the only state in the United States that provides this type of capability to ambulances. And these are necessary in times of disaster, where literally we are able to pinpoint where every ambulance is that would be available to provide support in these areas. An additional component of that is also that the units provide a Wi-Fi hotspot, which allows capability for many services to be able to transmit EKGs to ERs and to cath labs as they're transporting cardiac patients. We have also formed allegiance with the State Office of Rural Health in STEMI system development, which again, one of the critical components for EMS is for a patient having a STEMI or a heart attack is to get those patients to definitive care in the most effective and time-sensitive manner, to get them to a PCI facility where literally we are helping them to not lose more heart muscle. Again, the burden is back on EMS to transport these patients to definitive care for our stroke patients, for our cardiac patients, and that does create an additional burden on the EMS systems as they're trying to provide coverage for those counties. And in a lot of cases, like I said many times, it's in these areas that have lost hospitals and have an already increased burden on their healthcare system. We also have formed bonds with the Association of County Commissioners of Georgia and the Georgia Municipal Association. We are filling a gap through the grants that we're being able to provide from the Trauma Commission to handle some of the areas that have not been addressed recently. One of those is emergency vehicle operations. We have had several incidents in the state of Georgia over the last few years where we've lost medics and patients through ambulance crashes and different accidents that have created injury or loss of life. And one of the areas that we found that is critical for training of our EMTs and paramedics is the operation of the emergency vehicles in a proper manner. They are not getting that training as they're coming out of EMT and paramedic school, and we are working with ACCG and GMA to provide that training to them for safe operation of those vehicles. Mr. Chairman, I'd be willing to answer any questions at this time.
Thank you. Any questions from the committee, comments? Thank you, Kim. Next, Cindy Zeldin.
Thank you, Mr. Chairman and members of the committee. Thank you for the opportunity to provide testimony today. My name is Cindy Zeldin, and I'm the Executive Director of Georgians for a Healthy Future. We are a nonprofit consumer health advocacy organization that works to improve healthcare access through outreach and education, consumer assistance, coalition work, and advocacy. As you consider the healthcare investment needs of our state through the budgeting process, I ask that you consider two important steps that will strengthen our state's healthcare delivery system and facilitate better access to care for individuals and families in Georgia. The first is to preserve Medicaid payment parity. Many provider organizations and physicians have already spoken to this point and are working on this important issue, and we support their efforts. This is also more than an issue for healthcare providers, and that is an important point that we wanted to convey today as a consumer organization. This is very critical for patients and consumers. A recent study published in the New England Journal of Medicine that Dr. Hoffman referenced earlier found that the temporary payment bump resulted in an 8% increase in medical appointment availability, and the study concluded that payment rate increases are an effective strategy for enhancing access to primary care services. So as state policymakers consider strategies to preserve and improve access to care, and we know there's a statewide conversation happening now, particularly around rural access to care, the choices that you make around the budget really will have a big impact on access to care, and the evidence is clear that this strategy works. So we would ask you to preserve those primary care rate increases. Representative Gardner earlier asked a number of the speakers about how that might be paid for, and since that has come up a number of times, I wanted to state for the record that Georgians for a Healthy Future is strongly in support of increasing the tobacco tax, and not just because of the revenue that it would bring to the state, but because on its own it would reduce smoking, particularly among children in Georgia and adolescents. And that is really an important piece of a comprehensive health strategy for the state of Georgia. The second topic that I wanted to touch on is to ask you to consider strategies to draw down federal dollars that are available to Georgia to cover our state's low-income uninsured citizens. From the consumer perspective, this is one of the most important steps that Georgia can take to improve health access in a fiscally responsible manner for the state. We certainly understand that expanding Medicaid is a hot topic and a conversation that will involve a number of legislators from multiple committees, but it is also one of great importance that deserves attention and consideration as you weigh decisions around the state's health care budget. With my limited time, I wanted to just highlight some of the key findings, and I passed this out on the handout. That came out of an analysis conducted and was released last week by the consulting firm Deloitte, commissioned by the state of Kentucky. Kentucky is one of the few states in the South that has expanded its Medicaid program, and the early findings are quite compelling. They found that it has had a positive fiscal impact on the state, and that they were able to avoid $99.5 million in costs that they would have incurred had they not taken up this option. So obviously Georgia is a very different state. We're a larger state. We have different demographics, and we have different sort of healthcare system infrastructure dynamics. But we wanted to make sure that these findings were available to you, and we hope that you will consider them as you look at the entirety of the state's healthcare budget and picture. And so that's all I have. I want to thank you for the opportunity to speak today and share this information. I hope that you will consider Georgians for a Healthy Future a resource in your work, and that you will reach out to us if we can be helpful in any way. Thank you.
Thank you. Any comments or questions? Representative Gardner has a question for you.
Thank you very much, Mr. Chairman, and thank you, Ms. Zeldin, for being here and showing us what is happening in other states. I know that you noted in Kentucky that more than $1.6 billion came into the state of Kentucky directly to providers like hospitals and doctors. Do you have an estimate on the number of new funds that would have brought to Georgia?
Yeah, although I should say that I know Tim Sweeney from the Georgia Budget and Policy Institute is slated to speak as well, and I believe he's going to get into a little more detail about some of that, and it sort of depends on the number of years, but I believe the number that we had initially over a 10-year period, I'm going back to the analysis that Dr. Custer did from Georgia State University, was that it would be more than $30 billion over a 10-year period coming into Georgia. There's also an economic impact associated with that. It would create jobs and otherwise bring in state revenue from those jobs. But I would defer to Tim since he's brought those numbers with him that are a little more updated.
Do you remember how much it was for each year? For 1 year?
$3 billion.
$3 billion with a B?
It's 100% federal. It's 100% federally financed through 2016, and then scales down thereafter, and then it hits 90% federally financed in 2020, and that's where it stays. So there will be a 10% match. So there's it's largely federally financed.
And can we expect our taxes to go down then because we have not taken advantage of this opportunity?
That would be up to the legislature to decide.
Thank you. Any other member of the committee have a question? Thank you very much.
Thank you.
Tim Sweeney is next. While Tim's working his way up to the podium here, Representative Sims wanted me to recognize a special guest out here in the audience. Of course, you're all special, but it just happens to be her DOT commissioner and mine, Don Grantham. Glad to have you here today, Don. Thank you.
Good afternoon, Mr. Chairman and members. Thank you again for taking the time and for the opportunity to speak again. My name is Tim Sweeney. I'm the Director of Health Policy with the Georgia Budget and Policy Institute, also a nonprofit policy research organization looking at ways to increase economic opportunity for all Georgians. First, I would like to echo the comments from many provider groups and from Cindy around the provider payment increase that expired last year. It certainly is very important for all the reasons noted. I would like to add one thing. While it is noted that state funds are needed, the federal funds for that don't entirely go away. So I believe the $60 million that DCH has said is needed in state funds would still bring in more than $120 million in federal funds. So the impact to the health system, to the providers as a whole, is nearly $200 million. Next, I would like to also echo Cindy's comments about the importance of the Medicaid expansion and the larger larger concern around access to care. The opportunity for Georgia to extend Medicaid eligibility to hundreds of thousands of uninsured Georgians while bringing in about $3 billion of new federal funding every year would be significant. The generous federal match means that Georgia could extend coverage to about 500,000 uninsured Georgians for minimal state impact. Over the next 4 years, according to data released by OPB a couple years ago, new state spending to cover these Georgians would total about $575 million, whereas new revenue, as forecast both by the OPB study as well as the study from Dr. Custer over this 4-year time frame, would account for about $720 million. So over just the next 4 years, the benefit to the state would be a net of nearly $150 million. Dr. Custer's report also predicts that more than 50,000 jobs statewide could be created as a result of this new infusion of health investment. Also, the experience of other states suggests that have already implemented this suggests that we could see somewhere in the neighborhood of about $100 million annually in state savings in other programs where we spend state dollars to serve uninsured Georgians. In particular, states have seen savings in mental health programs, in public health programs as uninsured people get served in local health departments, and even in for providing health care services to some people in state custody in our prisons. As noted by Cindy, the report from the state of Kentucky shows that these benefits are no longer really theoretical. In fact, that Kentucky has found the economic impact and the jobs impact to be about double their initial projections. So I think that we can assume that the numbers suggested by Dr. Custer's report are very attainable. Indeed, 2 minutes is not long enough to go into all the benefits of Medicaid expansion, and I don't want to take up too much of your time, but I did want to note the incredible value to the state of doing so. And I do want to take one more minute. I was not really ready to do this yet, but since nobody else is talking about this, I would like to talk for just a minute about the item in the budget to eliminate state health benefit plan coverage for non-certified school district employees. According to the department, this would eliminate coverage for about 11,500 workers and about 10,000 or so of their dependents. While certainly I appreciate the significant financial challenges faced by the plan, not the least of which is the $135 million deficit in the public school employees portion of the plan, DCH testimony and separate emails to me indicate that this proposal would save less than $3 million. At the same time, a zero-based budget analysis suggests and has directed, and was included in the 2015 budget, has directed the department to produce a report and to, quote, describe a variety of options for reducing costs without further diminishing the value of health benefits received by members. And I think this would certainly diminish the value of those health benefits. And so I would just say that in the time when we are actually trying to look at this problem and come up with a larger solution to the financial challenges facing the state health benefit plan, that kicking 21,000 people off of coverage in the short term would be dangerous. So, thank you.
Thank you. Any questions from the committee? Excuse me, Representative Hughley, yes.
Thank you, Mr. Chairman. And thank you for your testimony today. Would you speak to us about the 10%? Of course, if Medicaid expansion 100% for 2 years and then 90% thereafter, people have a problem with this 10% notion that will be a long-term expense. Have you come up with what that is in real dollars and how the state would manage that?
Well, long term, the new state spending would amount to potentially $200 to $300 million a year once that full 10% is kicked in. And again, that depends a great deal on rather long-term forecasts as to how many people would get enrolled. Big picture, it would amount to a relatively modest increase in total state spending. I know it sounds like a lot of money in the short term, or just as itself. It would be less than a 1% increase in the overall state budget. And again, I think that it's important to not just look at the spending side that would go out, but the potential revenue that was forecast both in terms of the state income and sales taxes in Dr. Custer's report, and the additional insurance premium taxes that would be paid by CMOs, assuming we'd continue to use CMOs in Medicaid, would certainly offset a portion of that, as well as potentially finding savings elsewhere in the state budget, as we've seen in Kentucky and a handful of other states. And I think that when you look at all of those items together, it's not hard to imagine and indeed see why other states have concluded that over a 10-year time frame or even longer, that it would be budget neutral.
Any other questions? Thank you, Tim. Next, Linda Lowe.
Mr. Chairman and members of the committee, thank you so much for having this hearing today so that we can discuss the 2016 budget. Families First, I'm Linda Lowe, and Families First is a leading nonprofit family service agency in Georgia. Our mission is to ensure the success of children in jeopardy by empowering their families and helping their families improve their lives. We provide a lot of individual and family counseling, specialized foster care, adoptions, transitional housing, training in independent living skills for foster children, etc. At Families First, access to health care for the clients is a huge priority. And that's of necessity because the clients who come to Families First are in some sort of crisis, and that often involves some sort of health situation. One of the things our staff do is to try to help people get appointments that they need. And for some of the Medicaid patients, that is a challenge because of the difficulty of making sure that there's a doctor available who will take a new patient or be able to see somebody in a timely manner. For that reason, we want to add our voice to the others supporting achieving parity for the Medicaid payments for primary care. Those physicians are the front line, and that's where people, where the rubber meets the road in terms of folks being able to get appropriate access to the health system and not having always to resort to the emergency room. We also cited to you that same study that we were very interested to see, showing that the bump actually does what it's supposed to do and helps improve access. Our clients, though, who have no insurance face even more difficult barriers in getting the services that they need. While the children almost always are covered by Medicaid or Peach Care or some sort of private insurance, the parents often don't have anything. They often are not able to get coverage through their work because many of them are in low-wage jobs, and they don't have enough income to qualify for a subsidy on the health insurance exchange. They fall into that coverage gap that Cindy talked about. And because Georgia so far has not chosen to extend Medicaid as is allowed under the Affordable Care Act to these families, there's nothing much that they can do. It's just a bad situation, and so they end up having to seek out care sometimes in more expensive settings than they wish they had to. I'd like to ask you to look at the chart that shows the income levels at which people qualify for Medicaid in Georgia. It's the one with a lot of green on it. Often we find that people think that anyone below the poverty level in Georgia can get Medicaid, and that is simply not the truth. People also have to fall into the right category. If they're parents, their maximum income can be about 38% of the poverty level. You know, that's an extremely low income. Otherwise, they're deemed too wealthy to qualify for Medicaid. If they don't have minor children, you know, if the children are grown, then the adults can't qualify at all unless they're adjudicated disabled or are pregnant. So people really are out in the cold. We think that it's important to start a conversation about covering these folks in Georgia. The economics of it are very compelling, as Tim has said. We also highlighted the Kentucky study because it's fresh out. It's, you know, 2 weeks old or something like that. And it is a state very like ours in many respects, particularly in terms of the health status and all, which did choose this option. And if you look at the map, the two maps actually that are at the back of the testimony, you'll see that the hot colors, the reds, the oranges, and so forth, that were used to tent the map before the coverage was expanded under Medicaid and the ACA kicked in, shows that most of the counties in Kentucky had more than 15% uninsured and some far more than that uninsured, just as does Georgia. But just 1 year in to the Medicaid expansion and the rest of the ACA implementation, we've gone to the cool colors, meaning that less than 15% and sometimes less than 5% of the people in the counties are not covered. Do I have one more minute, Jesse, or not? Okay. I wanted to talk just a minute about some specific individuals. Sometimes it's hard to think about this in the abstract, but you know, I've got here a long list that I won't go into, you know, from at least 28 counties of people who would be eligible for Medicaid if we chose to expand it. I'm going to tell you about just a very few of them. These are working people. One woman who's a young woman and has a child who's got Medicaid lives in Spalding County, and she's making $7.75 an hour. She can't get insurance with that kind of income, but she does have some health conditions, and she already owes the hospital emergency room bills. With that income, she also has very little chance of paying those bills. But her income puts her over that level at which she can get Medicaid as a parent in Georgia. Another parent, this is a man raising 3 children, and his earnings are 79% of the federal poverty level. He can't qualify either, but both he and his kids need him to remain healthy. There's a young woman in Koda County she's 27 years old, and she's got bipolar disorder. Her medications run several $100s a month, and she can't get them. She doesn't have a child, and so she's not qualified at all, and she hasn't been adjudicated disabled yet. Eventually that might happen, but now she gets nothing. I could go on and on, but I think that it's really important for us to start this conversation and to look at Medicaid not just as a budget issue, which we all know that it is. I mean, we're all here every year and we see it, but also to see it as the tool that it is to be able to solve our state's health problems and actually to improve our economy if the experience of some of the other states holds true. Thank you.
Thank you. Any questions or comments from the committee? Thank you, Lynn. Next, Amy Lucero. You'll pronounce that for me when you get here. I don't think I did that very well.
Good afternoon, Chairman Parrish, members of the committee. My name's Amy Lucero. I'm here today as a CIS provider who's been providing physical therapy services for children in Georgia for over 20 years. The past 16 years, I've been the CFO and co-owner of All About Kids Therapy Services, providing occupational therapy and physical therapy to children in Gwinnett County suffering from orthopedic, neurological, and developmental disease and disability. I'm here today to ask you to support PTAG's request of the Appropriation Committee to align the CIS providers' rates with the current resource-based relative value scale, which, to clear that up, the question that one had on the rates, whether we are the same as the physicians, our rates were based on the resource-based relative value scale in 2000, in the year 2000. So they're 15-year-old rates. We haven't had an increase in, actually, I don't know how long. I think it's been over 17 years because there's never been an increase since I've been in practice, and there's only been a decrease, which occurred. There were a series of decreases taking away travel and things like that about 16 years ago. So we've only had decreases. We definitely haven't had any increases in over 17 years. With the exception of a few SLP codes that are new, so they have a more recent rate in there. And SLP, sorry, speech language codes. As you know, the past 12 years has brought significant change to healthcare across the nation. Our state has made great strides in its state funding healthcare programs and opening its doors to cover more children than ever before. As a CIS provider, I appreciated the dilemma this put the state in. Serving more children meant increasing funding to programs at a time when state funding was experiencing significant cuts. However, CIS providers have struggled over the past 10 years to adjust their practices to meet new requirements by the CMOs, DCH, Babies Can't Wait, and new federal EMR standards, and many have not survived the changes. I understand that there are others here, and I've been hearing it all day today, that everybody has many of these same issues. But I would argue that the CIS provider has taken on more than their fair share of the burden to open their doors to more children. I say this as one of the last surviving providers of PT and OT services in Gwinnett County for the Babies Can't Wait program in that district. My practice has served our community without prejudice of payer source for over 15 years. We have worked with the CMOs, with DCH, and with Babies Can't Wait program to ensure evidence-based, cost-effective services are being provided. But we are now one more erroneous mass reprocessing or added loophole away from closing our doors, and there's really no one that's going to be there to take our place. My practice is actively serving 828 children in Gwinnett County. 285 have ABD Medicaid, 248 have some form of a CMO, and 290 have private insurance. Simple math would tell you that these numbers indicate that 2/3 of our practice is Medicaid, which in itself would be more than our fair share burden from the state. But in reality, it's far worse. For the majority of the 290 patients with private insurance, nearly 90% has some form of Medicaid or Babies Can't Wait, or both Medicaid and Babies Can't Wait. We have patients that we literally have to request and track 3 different insurance authorizations for one plan of care. And the beauty of the Babies Can't Wait program for the consumer is that it doesn't discriminate. Rich or poor, you're only going to pay the Medicaid rate, up to the Medicaid rate at that. So what does this mean for my practice and the community CIS provider that specializes in pediatrics? Over 90% of our patients require additional administrative resources over and beyond the typical private insurance patient, and yet we receive payment at a 40% decrease. According to the DCH FY 2016 projections, updating the therapist reimbursement to 100% of the 2014 RBRVS's or Medicaid rate would represent an additional $11 million in funds needed for the state, from the state. This rate increase would restore balance to the system and ensure CIS children receive access to the care that they need. Any questions?
Thank you. Any questions, comments from the committee?
No. Thank you.
Thank you, ma'am. Next, Scott Maxwell.
Thank you, Mr. Chairman, member of the committee. I'm Scott Maxwell, and I'm here today speaking on behalf of the Georgia Public Health Association. This committee has been very good over the past 5 years for putting money in the budget for hold harmless for public health counties that would otherwise lose under a new formula that was instituted 5 years ago. This year we are just thrilled that the governor included in his budget recommendation money for the hold harmless. So today my appeal is a little different than it's been in the past 4 years. I'm asking you to hold that money in the budget and rather than insert it in there. I want you to know that we do not take for granted that amount of money, and that the individual counties that benefit from it tell me constantly how important it is to them. So we thank you for what you've done in the past. As you know, this is a 7-year phase-in. This will be the 5th year of that 7-year phase-in. But I'm happy to answer any questions you might have.
Good. Thank you. Any questions, comments? Thank you, Scott. Next, Mary Frances Williams.
Okay. I'm Mary Frances Williams. I'm here on behalf of the Georgia School Nutrition Association, and thank you so much for being here and listening to all of us talk about all of these important things. I want to talk to you about an item that is in the State Health Benefit Plan section of the DCH budget, and it is the language that says that to eliminate health insurance benefits for part-time non-certificated school employees beginning January 1 of next year. And I am imagining that many of you have heard from lots of bus drivers and school nutrition workers. I represent Georgia School Nutrition Association, as I said, and that's about 5,000 school nutrition workers throughout Georgia. That's school nutrition directors. It is also food service managers, and it is also just all the other part-time school nutrition staff. We acknowledge that there is a problem with the current state health benefit plan, but the cost of the health insurance for the non-certificated folks is not the only problem. The administrative costs for the state health benefit plan have increased substantially over the past 5 years, and I'm getting my information from the fiscal year 2016 zero-based budget analysis from OPB. And they state that between 2009 and 2013, administrative expenses were 4.8%, or about $139 million. And in FY14, they were 6.6%, or $186 million. They go on to talk a little bit more about how those administrative costs have gone up. We're very happy to hear from so many of you that you don't really have plans to eliminate health insurance benefits this year. And as Tim Sweeney mentioned, in fact, eliminating this particular group of folks will only save about $2.7 million, and to save that $2.7 million, you would knock about 2,000 employees' independence off of health insurance. So to me, it seems like hurting a lot of people for a little bit of money. We're concerned that to balance this out, DCH might go ahead with the plans to increase the per member per month cost, which was scheduled to be another $150, and I think it would bring the per member per month cost for health insurance for the folks I'm talking about up to about $750, $760. That's a lot of money for school systems to pay. And what a lot of folks don't realize is that in many school systems, the school nutrition programs, because they do make a little money supposedly, they are tasked with eating these costs or paying for these folks. And a lot of my nutrition directors are really upset. I was told by the nutrition director in Rockdale County that it would cost her $400,000 to implement this new increase, and she's like, I don't have that in my budget. I don't have it. I can't make it up. So I don't know what, I won't pretend to have the answers, but I will ask that as you look at solutions, please allow representatives of those most effective to be involved in the discussions. We We know that compromises are going to have to be made. We want to be part of the solution. We just ask that you allow us to be a part of that conversation. And thank you so much for all that you're all doing.
Thank you. Any comments or questions from the committee? Thank you.
Thank you.
Dr. Jeff Reinhardt.
Chairman Parrish and committee members, thank you for the hard work you're doing. I don't envy you. I'm glad I don't have your job. I am Jeff Reinhardt. I am a full-time private practice OBGYN. I also am here as a board member from the Independent Doctors of Georgia Association. I am the immediate past president of the Longstreet Clinic, which is a nearly 150 provider multi-specialty group up in Northeast Georgia, based in Gainesville. I am a clinical faculty member on staff, or as a member of the Medical College of Georgia, so I'm an instructor there, and I'm also on a committee called Pathway to Medical School, which is a grassroots committee to try to attract students into medicine, particularly for the practice of primary care specialties in the state of Georgia. I am here to speak really to support the continuation of the Medicare-Medicaid parity payment program you've heard so much about today. I also brought copies of the article you have in front of you. It's from the New England Journal of Medicine, which I quite frankly find dry and full of statistics. It's an interesting study. It was actually sponsored probably by the folks who provided the funding for the program to begin with, to see whether or not it was something that would succeed. And quite frankly, I believe it's the first in a series of articles you'll see. It not only succeeded, but they were able to find that really over about a 1.5 year period of time over which the data was collected, it really exceeded their expectations. As a private practice doctor, we see these patients in a variety of settings. We see them in our office, and a lot of these people who were affected by this, the new Medicaid recipients, most of them, we see them in the ER. I think it's important to recognize that part of the provision of care for people, myself, my kids, the poorest of the poor, yourselves, is that it has to be done in the right location, and it has to be done at the right time. The whole purpose of this program was to try to provide a medical home, a place for primary care to be provided to these folks that beforehand didn't have access to that, to treat things like asthma before it became so bad that they had to be seen in the ER and then hospitalized. I heard you ask a couple of the people, where are we going to find funding for this? Well, I told you about a couple of my hats because I think the funding comes from several places. And as I tell my kids sometimes, you spend $1 now, you might save yourself $100 on the other end of it. When I said this article is going to be the first in a series, I believe the next article you'll read is about the downstream effect of this increase in the provision of primary care. You're going to see that it's going to lead to decreased cost of care provided in the ERs and the acute care settings. I also think you're going to find that it will demonstrate clearly that we are able to attract more primary care providers to a particular geographic location. This study was done in 10 states. Georgia, thankfully, was one of those states. So they actually looked at us here in Georgia. We have a hard time attracting primary care folks. Specifically, that's family practice, pediatricians, and internists. You've also heard some things said about obstetrics. I'm not here to talk about that. That would be a bit self-aggrandizing, I agree. But as an employer, as a provider of primary care, attracting these folks here is a real challenge. Approximately 60% of residents trained in a particular state stay in that state. That means that we are losing 40% of the investment that this state has in those folks. And if we don't give them some mechanisms to pay back the average debt from medical school alone is $180,000. Average debt from undergraduate school is $139,000. That's the principal. That doesn't even include the interest on that. So these are kids. The medical students I teach are finishing on average with $220,000 worth of student loan debt. And when the average income for pediatricians is below $100,000, that is a heavy burden for them to carry. So perhaps the funding for this can come from places like not having to spend so much on recruiting primary care into the state. We have in this state a thing called the Rural Area Assistance Contract. It's a loan forgiveness program for people who are willing to practice in rural areas. I have a partner who did this up in Dahlonega. She no longer practices in that area. She paid off her student debt, did her years there, and moved on. I can give you the name of another individual who did this also up in Habersham County, an obstetrician, and you heard from Dr. Patterson today about how those folks are contracting into more urban areas. She did the same thing. Finished her time up there to get her loan repayment, which on average, well, I guess the maximum lifetime repayment is $100,000 per person. The budget for this, and it is a state-funded program, is around $1 million as I understand it. So that's $1 million we are spending because we are literally paying people. We are forgiving nearly half of their debt to go practice in a rural area. So I don't know what the actual dollar is on how much this parity payment would cost the state. I've heard 50, I've heard 59, I've heard 60, and recently I just heard a $200,000 number thrown out there. I don't know what the cost to the state was, but we're paying $1 million a year to pay these kids, these people, these new practitioners to go into more rural areas. It would seem to me that that dollar spent today might save us down the road in paying people to go into those more rural areas. Like I said, as an employer, I'm finding it increasingly difficult to place people in some of the rural communities where we practice, which stems from Rabun County all the way down into more populated areas like Gwinnett County. So I think your challenge as you look at this is not just to look at it as a budget item. It's not specifically just income for physicians. It's really about trying to find patients that access and find them the right place for care at the right time, and not just kicking the can down the road and inflicting further cost on the state on the other end of it. So I'm going to be quiet. I'll entertain some questions if you have any, but I really appreciate your attention to this.
Thank you. Any questions or comment from the committee? Doc, thank you for taking time to come be with us today. Next on my list, Margaret Ciricilli. Ciccarelli. Thank you.
If it's okay with the chairman, I have brought a page member, an educator from Gordon County with me today. It was our lobby day today at the Capitol. It was page day. And so I have one patient and dedicated educator who's come with me to speak. So thank you for allowing that. My name is Margaret Ciccarelli. I am the Director of Legislative Affairs at PAGE. Thank you for allowing us to speak. PAGE continues to call on legislators to continue including non-certified school employees in the state health benefit plan. We appreciate that y'all have made provision for that in the budget because these employees are critical to functioning school systems, and they care first and foremost about student outcomes, but they can't do their job insurance because that's what many of them work for. It's certainly not the salary or other benefits. By cutting those benefits, the teachers in those close-knit communities are concerned that they will lose drivers and not be able to get their kids to school if those drivers lose insurance. So I also want to speak briefly on behalf of the Georgia Association of Pupil Transportation. That group could not be here today because its current president was iced in Forsyth. He estimates that as many as 40% of school bus drivers would be affected by the change, those drivers and their families.
And as I mentioned, local districts are very concerned about that, particularly in rural Georgia. So we appreciate again that y'all have made provision for that in the AFY 15 budget, and hope that that can continue in the 16 budget. And what we are really looking to do is to work with you for the future to make sure that there's a sustainable way to pay for this, to ensure that these special employees who are so critical to student services can remain insured in the years to come, even beyond the budget discussion that we're having now. And again, I have with me a teacher from Gordon County, Kelly DeGuire, who has a few comments about what bus drivers and other classified staff who might be affected by the change mean to her school community.
Thank you, Mr. Chairman and committee. I beg your indulgence. When Margaret asked me to speak, I wrote down a few words. And as I'm much more comfortable talking about Julius Caesar and Shakespeare than I am speaking to your esteemed committee, I'm going to read a little bit of what I wrote. I am the Page State Secretary, but I'm not a lobbyist. I am a teacher and educator in Georgia. I have been for 14 years. When I began teaching, a very wise mentor told me, you must do before you do anything else is make friends with the cafeteria staff and the custodians. And she was correct. They take care of us in every way possible. They run the school, make no mistake. And I work in a small school district with limited funds. We have already privatized parts of our nutrition and custodial staffs. We maintain full-time employees who work with funds just for accountability purposes. All the others are temporary workers hired through a local firm, which we only have one local firm that will do that for us because of the locale of our community. However, with temp agencies, we have found they do not do enough background research to prevent identified felons from being presented for jobs. If the state of Georgia does away with insurance for affected non-certified personnel, every school will be faced with the type of snipe hunt background checks that we must do now on top of what the temp agencies give to us. Employees like cafeteria workers and bus drivers and custodians who, let's face it, they take $8,000 a year jobs simply for the benefits will be eliminated, and we will be forced to go looking at through these temp agencies. So what can be done? I've heard you ask several people here today, okay, so where does the money come from? I don't know, but what I am suggesting that you do is send this issue to the governor's new education reform committee specifically designed for the state health benefit plan and let them study it. It's too important of an issue to decide in one budget year, one legislative year. Our bus drivers are the first face that our students see when they begin school, and I want you to ponder really hard, whose face do you want them to see when they get on the bus? Thank you.
Thank you. We have a couple of questions. Representative Quick has a question for you.
Thank you, Mr. Chairman, and thank you, ladies, for coming. I just want to try to talk about what this debate has been about and what this discussion has been about for a little bit. It's not that anybody wants to remove the ability of these employees to participate in the state health benefit plan. The question and the discussion has been their employer is not contributing sufficiently to the employer's share for them to participate. And as a result, it's being subsidized both by other state employees and teachers, as well as perhaps in the future going forward, state taxpayers. So that's really the discussion. And before anybody goes off on a tangent, I rode the bus as a public school employee in Coleman County, Alabama. I have fond memories of John McNeil, my bus driver for that period of time. But it is a policy question that we really are struggling with here. And so my question to you ladies, if you know, is over the same period of time we've been struggling with this, which I think is the last 3 or 4 years, do you know how much school administrators' salaries have increased over the state of Georgia by percentage?
I think Kelly has a response to the first part of your question, but as to the second part about administrative salary increases, unless they were due an increase due to extra training or extra years of experience, and many educators, particularly administrators, have maxed out on that salary schedule for experience. No educators, no administrators have received pay increases unless they got one on the training and experience salary schedule. And in fact, many administrators from the senior level down to the classroom teachers have been furloughed during the last several years. We've seen some lessening of that in the last year, but we see school systems as an organism, and they certainly a cohesive unit, and I know that they see themselves that way, hence the outcry about this issue. Everybody from the senior level staff to the bus drivers have really seen some pay cuts during the recession. So we appreciate you highlighting the salary issue, but I'm not sure that we have seen, as I said, large salary increases in the administrative area.
Let me phrase it. I'm sorry, I didn't mean to interrupt you, but let me phrase it differently. In terms of the percentage of administrative salaries and cost as opposed to instructional cost, that percentage, has it risen over the last 3 or 4 years as a percentage?
I don't know the answer to that question, but I'll be happy to try to get that for you.
Thank you.
I was just going to say that I spent a great deal of time with my representative, John Meadows, before I came in here, who, as you know, sells insurance for a living. And he spent a good deal of time explaining to me the give and take of trying to get the local systems to help with purchasing the insurance in a more equanimous measure with the state, so it wouldn't be so one-sided on the state. And I completely understood everything he said. I think the point of what I would like to see happen, though, is nothing to happen quickly. It needs to be a slower process. The school systems are already overburdened, and despite what you may have heard from some elected officials, we still have furlough days. And there are still lots of school systems that have furlough days. My school system is not operating on 180 days now. We don't have enough custodians. I clean my own room. I have a resource officer full-time. We don't have a lot of things that we used to have. Our music and arts programs have still been cut. There's a lot of money missing that I just don't know how the local school board can come up with the money to participate in the healthcare program of non-certified employees in 1 year, while they're also dealing with getting all these other things back in the budget.
Any other questions? Thank you, ladies.
Thank you again.
Last on my list, Nancy Paris.
I'll strive to be brief and to the point. Mr. Chairman, thank you so much for having me. Thank you, committee members, for your interest and attention. And our board members asked me to convey to you in particular our appreciation for your coming to Grady to see the program there and Georgia Core's impact in one of our research network sites. So thank you very much. I represent the Georgia Center for Oncology Research and Education. I'm Nancy Paris, its president. We were created with funding from the tobacco settlement about 12 years ago, and we're very pleased that $500,000 was recommended in the governor's budget for fiscal year 15 for Georgia Core, and this comes through the Georgia Department of Human Resources. I'd like to tell you just a couple of things about what we do and our model and why it's successful. I know that you know how important cancer care is in this state, and I'm going to make an assumption that probably all of us have been deeply touched by cancer in our homes, our churches, our communities, our workplaces. There will be about 50,000 people diagnosed with cancer this year, and we've come to serve an increasing number of those individuals through our research network of 24 partners across the state and our board of cancer experts from, again, across the state. We created Georgia Core to help provide access to new clinical trials and cancer treatments. And if you think back 12 years ago, you might have had a much dimmer view of the quality of cancer care in the state. We had higher incidence of cancer and higher mortality rates. And everything that we're doing is designed to bring higher quality care, more cost-effective care through shared resources by stimulating collaboration and access to new research opportunities. So our research network now has over 600 clinical trials that are offered in the state, and this ensures that Georgians have the latest access to the highest quality care. We also have found that collaboration among physicians and researchers is very important to improving access to treatment through clinical trials and through evidence-based care. And when I talk about experts and when I talk about collaboration, it's not only in the academic setting or the institutional setting, but really at the community level, because there are many local experts. And they're experts in centers where we can reach particularly vulnerable populations from some of your communities, the elderly, and rural populations and minorities who have a higher incidence of cancer and suffer more greatly from its effects. The reason that we know that what we're doing is working is kind of multifold. I mean, I pointed to the increase in the number of clinical trials in the state, which means that Georgia is a leading state in cancer care and research, and this was untrue a decade ago. We have, through our research network, we're successful this year in securing multiple grants from the National Cancer Institute, and while we're very proud of the $500,000 investment that's recommended this year from state tobacco settlement funds, that represents only 20% of our budget. So we are attracting grants and contributions to build our budget. The new grants from the National Cancer Institute were awarded to their new model of care, which is community oncology research programs in core. And there's one at the Georgia Regents University. We're very proud of that. Of course, you may know that Winship Cancer Institute at Emory is an NCI designated center. We're proud of that. But the partnership that Georgia Core participated in has 6 partners that received an NCI grant of almost $6 million. And the partners are Northside Hospital Cancer Institute, St. Joseph's Candler in Savannah, the Medical Center of Central Georgia in Macon, the John B. Amos Cancer Center in Columbus, the Harbin Clinic in Rome, and the Northeast Georgia Medical Center in Gainesville. So we were able to put together a group that can achieve on par with what a Georgia Regents or an Emory University can achieve through collaboration, and this extends care that's available and brings resources to your communities. I'm just going to mention quickly another success that we've had, which is the breast cancer license tag. Thank you all for buying these tags. Some of you remember when this legislation was enacted, and maybe you've had a tag for 14 years or so. $22 from every tag that's purchased or renewed goes into a fund we administer. And committee members, there is a map of the state of Georgia that shows where the funds have been disseminated, about $2.3 million in the last 2 years, and Georgia Core makes these grants using recommendations from volunteer reviewers. We're most appreciative, again, of your support and your leadership, really taking on that legislation. And finally, I will tell you that a report came out from the American Cancer Society just a few weeks ago that pointed to declines in mortality nationally. And what what extraordinary accomplishments our nation has made. And while the drop in cancer mortality in Georgia, and this is the gray and the yellow graph that you have, mirrors the national average, we're still not quite where we need to be. So Georgia's yellow line is just above the national average, and we want to make sure that we're taking care of accessing every possible national resource to bring the best care and treatment to our citizens. One of the tools that we use to do that is called Georgia Cancer Info, and I believe you know we have an online cancer information center. 70,000 individuals have used that this year to look for doctors and treatment sources and trials and community resources, and we're asking for your consideration of an upgrade of that online center with an investment of $100,000. We would secure $100,000 in private funding, and we would be able to strengthen this for the survivors and patients and physicians who depend on this to access appropriate care and treatment. So I thank you for your consideration, and I'd be glad to answer questions if you have any. Thank you, sir.
Thank you. Do we have any questions?
Most appreciative.
Thank you. Ms. Parrish is the last that I have on my list. Is there anyone here that wanted to speak that did not get on the list that we overlooked or anything? Yes, ma'am. Okay. Come right up here, please.
Mr. Chairman and committee members, thank you for your time today. I know it's been long, and I have a letter on behalf of the chapter. I represent, again, the Georgia chapter, American College of Physicians, representing internal medicine internists in the state. And we have many of the same points that have been stated, so I'm not going to take your time to restate them. The one thing I did want to share with you is that in 2014, the American College did a study of their physicians who participated in the parity program and asked what would happen if it wasn't continued, and 40% said they would decrease the number of new Medicaid patients they accepted, and 6% would drop out of Medicaid programs in their respective states. So I wanted to share that because I think that highlights too some of the excess that's already been stated. So I will leave the letter with you, and if you have any questions.
Thank you. Any questions, comments from the committee? Thank you. That concludes the folks that have signed up with us that wanted to be heard today. I want to thank all of you who testified and all of those of you who attended and our committee that have been here with us all day and worked hard at this. And I want you to tell all those that left early that we're having a drawing and their name is not going to be in the pot, so they missed out on that. But thank you. We appreciate y'all coming and what y'all do to try to help the folks in our state. Thank you very much. We're adjourned.